As providers, we're in a real bind because we have an ethical obligation to treat our patients, and we're not really able to do that in the context in which we were working. So essentially we had no choices except to start advocating, but once you start advocating, then you're subjected to retaliations.
We're all in the field. We in some way or another are connected to this, and made some choices about it. And I did as well. I'm a psychologist. I've devoted my entire career for this, and I've been a manager and a chief of service, and had accolades at Kaiser for 30 years. And in the last 4 years since I've taken up this issue, like Mindy, I've had corrective actions for illicitly using a fax and those kinds of things. But in a sense, that's a sort of a byproduct, and it's an unfortunate and sad, commentary about an organization that in their compliance materials says do the right thing and speak up for things, and then when you do, you actually get punished for it, and in a kind of a loss of a moral compass, really, and really with no excuse for it given the kinds of profits. This isn't a strapping organization in the county that's trying to get money to get enough chairs and enough staff to get basic services done. This is an extremely successful corporation.
I just want to recognize the courage of the clinicians who've stepped forward, like Dr. Scoia, Dr. Ginn, and dozens of others, because it's only through their whistleblowing activity and bringing these issues to the attention of regulators and the public and testifying in public forums, meeting with government regulators, that we've been able to bring this to the public and initiate these regulatory sanctions that we hope will improve the care. And they've done it not out of self-interest. In fact, it's put their careers and professions on the line. Many of, they themselves and many of their colleagues have suffered retaliation, firings by Kaiser.
Welcome, everyone. My name is Sal Roselli, and it's really a pleasure to welcome you here. I'm glad you had the time to do this. I'm the president of the National Union of Healthcare Workers. We all share a common bond, and that is, the goal to accomplish parity, for mental health care, with physical health care. And we all share the common bond of working in the mental health care field. NUHW is not a new union. It's a relatively new name. We were founded in 2009, and the founding of our union was through a hostile takeover by SEIU here in DC of this very large healthcare union, 150,000 hospital workers in California, over a dispute about relationships with employers that are very linked to healthcare workers being able to advocate for their patients. We currently represent 11,000 members in California, including 2,500 licensed mental health clinicians at Kaiser Permanente, including all of those classifications and those responsibilities. I say we're not a new union because leaders like me, like Fred and others, have been representing healthcare workers, Kaiser workers in California since the early 80s. So we know this employer well and have been through decades, right, of changes in terms of their leadership teams, and have seen cycles of them from the early 80s being the employer of choice and provider of choice, and really engaging their healthcare workers and how healthcare is given, to late 80s, early 90s with the corporatization of healthcare totally being focused on the bottom line and not the quality of care. Through the next decade, went back to a level of high collaboration where we had a common goal of making Kaiser Permanente the healthcare provider of choice, and worked very well together. And then the late 90s, beginning of this century, going back again to where over the last 5 years, Kaiser's been so driven by the bottom line. Each of the last 5 years, unprecedented profits, $14 billion in profits in the last 5 years, with a $30 billion cash reserve, while not providing adequate care, especially mental health care. When we went to bargaining with Kaiser in 2010, these clinicians put forward just huge problems in staffing and actually violations of California laws about access to care. And Kaiser dismissed it, would not even talk about it. So we surveyed scores of our clinicians all over the state and put together a white paper that's also in your packet called Care Delayed, Care Denied, and presented that to Kaiser and wanted to work with them toward solving this crisis. Again, they dismissed it, would not talk to us about it. So we filed a complaint with the Department of Managed Healthcare, which is the regulatory agency of HMOs in California, and an investigation started. And it took a couple of years. And it's just one of many examples that we experienced of Kaiser's inappropriate influence with government on multiple levels. Finally, a couple of years after it was filed, in 2013, DMHC announced a $4 million fine against Kaiser and a cease and desist order because of the violations of California laws. Kaiser filed objections to that back in 2013. What's supposed to happen is an immediate investigation and hearing. Again, inappropriate influence with government. Another year goes by, and finally they were forced into a hearing on Labor Day of this year, actually. And we learned that over Labor Day, that our governor's office was willing to settle this without a hearing, and we successfully derailed that because the settlement was not appropriate. On the day after Labor Day, Kaiser came into this hearing. The judge ruled that it would all be public, against Kaiser's wishes, and overnight, literally, they dropped the appeal, paid the $4 million, so that none of the information could be public. September of 2013, we filed a lawsuit with the California Healthcare Benefits Exchange. This is the vehicle in California to administer the Affordable Health Care Act. And the lawsuit was based on, our position was Kaiser should not be allowed to enroll folks under Obamacare because they're breaking the exchange's rules itself until they fix the problems, the access problems. And back then, we knew that Kaiser could stand to gain hundreds of thousands of new members, right? We knew that they were not adequately taking care of their current members, and the addition of hundreds of thousands of more members would just make the crisis worse, right? Again, inappropriate influence with government. They tried to kill this lawsuit, have it dismissed. And to make that long story short, a year and a half later, it's now progressing, and we're in the discovery phase, and all of their motions to dismiss and not allow us to get information have been defeated, and that lawsuit's going forward.
Many times consumer groups, they can't see inside the system, they can only get to the outside. And what's remarkable here is through clinicians, we can sort of pull back the curtain or lift up the hood and see the inner workings of this giant HMO and see internal documents. And so what we have also in the PowerPoint are a number of internal Kaiser documents. To date, we've provided more than 500 pages of internal records to the regulators. Kaiser, obviously the largest HMO in the US, 9.5 million members. It's growing rapidly. The Obama administration is cited as a model for the new healthcare reform, given its coordinated system of care. And it's growing rapidly. Last year in California, it added about 250,000 new members, roughly 400,000 nationally, and it plans to expand on the East Coast. California is its largest regional market, perhaps 80% of its membership, and it's its oldest and most developed sort of infrastructure and systems, policies, protocols. So the practices we see in California are taking place elsewhere, and we've seen internal records that evidence this. We spent about 6 months. We did a survey of clinicians statewide. We reviewed the regulatory history of Kaiser, looked at legal filings, did open-ended interviews with both clinicians and patients and advocacy organizations, and prepared this 35-page report with 4 major findings. First major finding, excessive wait times that were in violation of the California regulations. In California, the legislature has adopted what are called timely access regulations, and it requires HMOs to deliver care, a variety of care, within certain time frames. So for example, a routine, non-urgent mental health appointment has to be provided by the HMO within 10 days of the patient initiating a request for such an appointment. Urgent mental health appointments must be delivered within 48 hours. Our clinicians reported in these surveys that 90% of the clinicians reported there's insufficient staffing in the clinic to provide patients with timely return visits or treatment appointments. 75% reported that they are frequently or very frequently forced to schedule patients further into the future than is clinically appropriate. Number 2, We found evidence of cooking the book, as we call it, cooking the books, but falsifying appointment records. They used a variety of mechanisms to falsify appointment records. The most prominent was the use of a parallel set of paper records that accompanied their internal electronic medical records. And the parallel records had the accurate wait times, which were far in excess of the state requirements. And we believe they, used this system in part to so regulators would have difficulty discovering the wait times. Number 3 was an over-reliance on group therapy. So rather than providing individualized care through individual treatment appointments, the sort of primary mode of delivering care is to push patients into these groups. And groups can be fine for some people, and they work wonderfully for some people, but it's not a cookie-cutter approach. Others, it doesn't work. We found that they use it as simply a cost-saving measure, pushing patients in to these groups rather than even offering individualized appointments. So this was our 4th conclusion. We found a practice of what we call shortcut intakes. The clinical and community standard for a diagnostic appointment for a first-time patient is to do an entire diagnostic review that would take an hour or an hour and 15 minutes. It includes medical history, treatment history, family and social history, etc., from which the clinician would then arrive at a diagnosis. Kaiser was booking these patients into 30-minute appointments. So in effect, they would get 20 to 25-minute diagnostic appointments. And this can produce, real problems. A rush job on a diagnosis, it produces a misdiagnosis and a sort of mistreatment of the patient. Timeline, Sal mentioned it. We filed this report in 2011 with the state regulators. In March of 2013, the DMHC issued their investigatory findings, a 22-page report that found, quote, serious and, quote, systemic violations of state law, including the California Mental Health Parity Act and the Timely Access Regulations. And then in June of 2013, after issuing the March report, the regulators found that the problems were so serious and created such risk for consumers that they had referred the report to their enforcement arm. And the enforcement arm then several months later announced a $4 million fine. It's the largest fine that this agency has ever issued for a mental health violation. They also announced at the same time the imposition of a cease and desist order. In other words, they ordered Kaiser to cease and desist from committing further violations. And they also ordered they were going to conduct an expedited follow-up survey of Kaiser to determine whether Kaiser in fact was improving and fix these problems. So the current status, I guess a good question is, since the cease and desist order, has Kaiser fixed the problem? What's the status? The core underlying problem is inadequate numbers of clinicians on the floor inside the clinics to deliver adequate and appropriate care in a timely fashion. Since the regulators imposed this $4 million fine, Kaiser has only marginally improved the staffing levels. And instead what it's done is, we call this sort of squeezing the balloon. But if you were to think about the clinical resources, a portion of them assigned to assessments or diagnostic appointments, and another portion assigned to treatment appointments and all the subsequent appointments. Kaiser they're trying to squeeze the balloon and redeploy its clinical resources away from treatment and towards assessments, because they believe that the regulators are principally involved in the time frame for the first appointments, not the second or third. So what this produces is, and what they'll do is, they impose new sort of productivity ratios on clinicians that require them to do X number of intake assessments or diagnostic appointments a week, which means there's less time to do the follow-up visits. So patients will get in, although you'll see some records in a little bit. In many clinics, they're not getting in even under the timely access standards. But once they get in, they have to wait weeks and months for a follow-up appointment. Clinicians report today that the average wait time for the first follow-up appointment is between 1 and 2 months. This has large impact on patients. I mean, the DMHC, one of their reports describes, it says Kaiser's deficiencies are serious and may have put some of its members at risk of harm. We know that in fact a number of patients have been harmed. What are the effects on patients? We see increased morbidity rates, longer recovery rates. Obviously, if you can't get treatment, your condition will persist for many months longer than it should. were you to receive timely and effective and appropriate care. We also see increased utilization of ERs by patients and increasing rates of hospitalizations. The other phenomenon we see is that patients just become incredibly frustrated, that they can't get the care, so they'll simply drop out of care. And then lastly, increasing mortality rates in reference to the suicides. So in addition to this action by this state agency, the Department of Managed Healthcare, there's a number of other regulatory and legal actions underway that I wanted to mention. Something totally separate from what we've done, but the Department of Managed Healthcare issued a cease and desist order against Kaiser in 2012 for violations it was committing with respect to autism spectrum disorders. And basically they refused to provide therapies to children with, a variety of therapies to children with autism spectrum disorders. Speech therapy, physical therapy, occupational therapy. And the department stepped in and ordered them to begin providing those. Subsequently, there was a lawsuit by the families of Kaiser patients against Kaiser for withholding this care. They also, the parents had to go out of pocket, pay out of pocket to get the care that Kaiser should have provided and failed to provide. A year ago, or July of 2013, Kaiser reached an out-of-court settlement on that class action lawsuit and agreed to provide consumers with up to $9 million to reimburse them for the monies that they had paid out of pocket for the care. Sal mentioned that there have been class action lawsuits. So these are filed relatively recently. The Futterman, Eagle, Dion, and Kerr. The first three have allegations that Kaiser has violated these timely access regulations as well as clinical appropriateness standards. The fourth one alleges that Kaiser is improperly dumping severely mentally ill patients onto county health systems. And basically, and we've seen this in our clinics as well, but when managers will instruct patients with severe mental illness that, look, you're not going to get good care here at Kaiser, you're going to get much better care at the county. So what we suggest you do is disenroll from Kaiser and go to the county, because you're going to get way, way better care. There's also a case that's, tragic in Georgia that was filed recently, March of this year. But this is the case of a 72-year-old man who was hospitalized for psychosis, paranoia, delusional thinking, impaired judgment, physical aggression, and other conditions. And he's a Kaiser member. And for some time was hospitalized, discharged. Then Kaiser provided sort of failed follow-up care. He was in the midst of a 3-month appointment wait. His wife was expressing concern about him when he attempted a murder-suicide. He unfortunately murdered his wife of 40 years, and he's now in jail for homicide. But this case is before the court. But I guess it points to, and we've seen unfortunately these tragedies that grab headlines. But the conditions we've seen of the failure to deliver care can produce tragic outcomes like these. I guess it's just important to note. So let me now walk through some of the records. Again, we've filed more than 500 pages of internal records with regulators, but I wanted to show you the kinds of things that we see and the evidence that exists for the violations. And all of these come from after the period when the state issued a cease and desist order and its $4 million fine and ordered Kaiser to fix these problems. So this is an internal document from Southern California. Here's the date, September 3, 2013. And you'll see it's this is for one of their clinics, Downey Medical Center Psychiatry Department. And they're looking at the category of appointments, routine behavioral medicine appointments. These are the appointments that are supposed to be delivered within either 14 calendar days or 10 business days to a patient requesting care. So we see here, here's the average daily wait in April of 2013, 20 days. And then the percent of patients who were booked within the state standards. So you see 50 and 56%, so they're way beneath. Many patients are not being cared for in a timely fashion. These are managers doing this action plan to address the steady state and suppressed demand. And they describe a number of actions. One is, and we've seen this they've implemented these things called rapid access clinics, and elsewhere they call them cluster intakes. But basically, it's a similar scheme to what the airlines use, where you basically overbook. Dr. Ginn was talking about this last night, but you have 10 appointments available, you book 15 appointments in, 15 patients to come in. And this is with reference to the rapid access clinics. The other thing, they talk about treatment plan options, none of which identify individual therapy, individual care. It's all intake plus group therapy. Starting group therapy classes, but again underscores this over-reliance on group therapy as the only treatment modality because it's a cost-saving measure. And we have internal documents from Kaiser that describe the huge financial savings they enjoy as a result of using the group therapies rather than individual care.
So my specialty is behavioral medicine. I treat people I treat the psychological aspects of major medical illnesses. And I'm also a geriatrician. So my patients are coming in with high demand, right? They need a lot of care. And about 2.5 years ago, I started writing my management to say I couldn't provide that care and I needed help. And so in one of the letters I wrote, I said, because of the lack of follow-up availability, my patients had been waiting 3 months for appointments, and it was dire. But because we're doing these intakes, I was seeing 25 new patients a month. And because we're doing these intakes, I have no room to put anybody, so my returns get farther and farther out. And when I wrote this letter, my patients were waiting 5 months to come back and see me. And so I said that in the last year, my return access had become more and more compromised, and that I wrote them, I said, I can't take a patient who has 6 months to live and tell them I'll see them in 5 months. We had 30, 35-year careers as psychologists, and never any problems. And we probably, once I started writing emails, was brought in for so many disciplinary meetings, I can't even count. And they were all ridiculous. You know, somebody didn't like my tone in the conversation, or I didn't call in sick correctly, or, you know, whatever it would be. But every single time we would get called in, then we would have to defend ourselves. So my joke was that we had 3 jobs. We had to see our patients, we had to advocate for our patients, and then we had to defend ourselves. And I think each one of them took up equal amount of time and equal amount of energy.
We have spoken up, and people have said this and courageously presented data and information that rather than the risk managers, officers, physician-in-chiefs, and executives, rather than saying, we have a problem here, let's at least look into this, let's take it seriously. There's been wholesale across the board denial and minimization and a kind of a caricaturizing our efforts. You know, as if say, well, this is all union stuff. They're just trying to get a better union contact. As if Mindy and I, as if me after 30 years of doing this, am trying to get better, you know, dental benefits or something. That's really what this is all about. If we get a better dental benefit, we don't really care about those patients. You know, who cares about them? We just wait. And it's offensive, and in a sense, it inspires me more. I just feel there's a sort of sense. There's many things I could do with my career, but this is the most meaningful thing I've ever done.
Is this the lady that they're asking to resign?
No.
It's so wonderful to be here.
No.
I ran for office for the first time and became a county supervisor. As a former healthcare provider, I am in lockstep with you and your fight against Kaiser. Because when I ran on healthcare issues and wanting a healthier Sonoma County, I didn't expect that I would become a poster child for suicide prevention or mental health parity. I cared passionately about mental health. But what I didn't know was that on January 18th, 2011, when I came home from a board meeting, my husband had tragically taken his life. This was not a choice. It was a tragic outcome of his healthcare provider, Kaiser, to provide adequate treatment. And that has got to stop.